Good morning, everyone. It's a pleasure to be up here. I think this is my first in-person conference since pre-COVID. This panel is one of the most important in terms of the themes behind Foundation for a Better World, from the perspective of healthcare and human health. And to get started here as well, I was telling Othman, this is super exciting. I think this is one of the most diverse representation here on stage. And hopefully that inspires a lot of people here to move into healthcare, and that there's a lot of opportunities for a lot of different types of people from different walks of life. So to get started, Anmol and Othman, I'd love for the two of you to introduce yourself, to tell us a little bit about the background and the companies that you've built in the space. This is exciting as well. We're representing all different aspects of healthcare, who you serve and who your stakeholders are, and why AI, at this moment of time, we're about 5 or 6 years into this, but it's still its infancy, why it's important to your specific area that you're focused on.
Yeah, great to be here. Thanks again for the opportunity. So my name's Anmol. This is nostalgia from the MIT Media Lab days. So background, I've basically done machine learning and AI for healthcare for the last, I'd say, 15 years. Started a company called Ginger out of a spin-off of my PhD thesis. Ran that as founder CEO for about 8 years. After that was the chief data AI scientist for a company called Livongo, which was the first IPO in digital health in chronic conditions. And then Livongo was acquired by a company called Teladoc. So I served, as part of that acquisition, the chief AI data scientist for the global business of Teladoc. So it's a $2.5 billion revenue business. 80 million consumers globally. And so across those, I've had a chance to see machine learning and AI in what I'll call this kind of digital hybrid health revolution that's happened in the last decade for mental health initially, chronic conditions like diabetes, and primary care and telemedicine in my most recent stint. So I think it's sort of shaped for me that there's this new world of healthcare that we've sort of marched towards, and I kind of talk about some of the AI use cases as we go through the conversation. But the new world is fundamentally kind of like has different systems, different constraints, different ways of operating, and I think technology, machine learning, but generative AI as well, I think they have an important role to play in that. So that's kind of like what keeps me going. So just wrapped up my stint at Teladoc and starting a new company called RadiantGraph, which we'll be announcing in the coming weeks. So glad to be here.
And Anmol, before I let you go here, the one question I have for you, specifically in the mental health space, healthcare is unique because we don't always generate our own data. So can you talk through a little bit around how teams like yours acquire the longitudinal data for this? And is healthcare primed right now for a lot of these different tools to begin to apply to these data sets?
Yeah, so I'll kind of give you the way we've done it before, and I'll also talk about the change that's happening in healthcare. I think healthcare for a very long time, and I say this with love and respect for the healthcare community, but also with candor, which is, I think, resisted AI and machine learning use cases, and there was always friction. And so the path that existed for a very long time, I think, was one of two, which is you either become a provider or you become a payer, right? And so you've seen, when you think of the digital health companies or hybrid health companies that have scaled, what we were doing at Ginger and Livongo, or what you guys are doing at Color Imagine, you're kind of going either becoming a digital-first provider, right? So I had an interesting board meeting in 2016 or 2017 where I was like, hey, we're just going to go off and hire psychiatrists, hire therapists, and be an AI-enabled provider because it's so hard to get the existing system to adopt technology. And so to answer your question of how do you get data, right, it was one of those ways, which in order to make the change, you actually had to go in and sit in the economic model of how healthcare works, right? And it was sort of the AI was embedded in like becoming, replacing one of those two. My view today is that because of the advancements and what the pressures that incumbents are facing, large health plans, large health systems, even incumbent kind of large companies, I think that is changing. And I think that's a view where I think in the last decade, that today I think you sit down and you go to a health plan conference and sitting there and like, hey, we need to do something with ChatGPT, right? We're not sure what it is, but we're going to do something with ChatGPT. So I think that has changed. And I think it's an opportunity to now think about partnering with those organizations more efficiently. My guess is, to what we heard earlier today, that the willingness to partner, and partner means like running AI systems on top of their data, on top of their clinical warehouse, obviously with all the like privacy and security and all these other things, I think is much easier, or the door is sort of a little bit more open today than it was in the last 5 or 7 years.
Thank you. Othman, I'm putting you on the hot spot now.
All right. Good morning, everyone. Good to see a lot of folks I hadn't seen in quite a while. So Othman Laraki, my background is a computer science and software engineer. She did computer science in a mediocre school down 101, but was lucky enough to go to grad school at MIT. After that, I worked at Google for a number of years, early product managers there. And it's kind of interesting to kind of like think back now, like how far things have come. Like I remember for the first time hearing from the AdWords team that we were running a million parameter model for ad targeting and it feeling like just completely mind-boggling at the time. And just kind of right now, like, I mean, just the orders of magnitude of change and so on is just really exciting. And, but fast forward a few years, about 10 years ago, I started a company called Color. So got into the healthcare space. A lot of engineers who get into healthcare will tell you it's this, you know, in part because you did not know what you were getting into until you actually kind of start figuring out the space. But at Color, we started off as a genetics company. Over time, kind of like what Anmol was talking about, in healthcare, fundamentally, I think one of the first insights a lot of engineers get when you start getting into the space is that healthcare as an industry does not metabolize progress very well, right? Like it is a really hard place to get raw technology adopted at scale because of the business model and market access challenges. So over time with Color, we started off as a deep genetics company, but really grew into a broad services organization that runs large population programs. So for the last couple of years, we've done about 40 million tests or immunizations or courses of treatments delivered to people in large public programs. So half of our work is in public sector, so with the NIH or the CDC or Departments of Public Health. And the other half is with large employers, so serving populations directly to manage and prevent risk of cancer. I think actually right now the entire generative AI cycle is one of the most like exciting, like new sets of building blocks that I think will be deeply transformative in healthcare. So really excited about the discussion today and have a lot of thoughts about where things may go and where we're putting a lot of work and seeing some really exciting progress happening across the board.
So Othman, let me start with you then on what you've just said. Where are the exciting enhancements with generative AI? What is available to us in a data set of genomics? What can you begin to think about that you couldn't before?
Sure. Not just only genomics, but I think so. A few thoughts of, I think like three. And I don't think these are going to be comprehensive in any way, but like three areas that at least we're spending a lot of time on are. Number one is in healthcare, as everyone knows, like there's a huge amount of data that gets generated, but also like a lot of very diffuse information that's available that historically had not been incorporated or used to in how we care for people, right? Like, so we are always now spewing a huge amount of signal that is relatively sparse, but has currently no way to find its way into how your healthcare is managed. Like, literally a picture of your face today can probably actually provide a lot of information about whether you're overweight, whether you have likelihood of depression, et cetera. And that information today is completely isolated from how care happens. So I think that's number one. So really starting to make use of a lot of diffuse signal that is available and marginally free to generate and can be very impactful. I think number two is that healthcare is a very analog business in many ways, right? Like, huge amount of healthcare is about interacting with people that are relatively highly trained, but where we try to get them to be very systematic, right? Like, you want, the thing that your doctor tells you to do to, manage your cancer risk or manage your, risk of diabetes and so on, to be very consistent, but it requires a decent amount of training. And so that's the type of thing that these language models, I think, actually are going to end up being extremely good at, to be able to provide, a computerized way to provide like access to relatively decent level of skill. And so, and I think that's kind of number two. And then on the third one, I think there's another kind of big dimension is around like all of the, like, in some sense, like beyond just the interface is like starting to take some of the cost of some of these services that today are seen as very scarce, where there's a huge amount of health inequity. So for example, the cost for a person to get the, recommendations from your doctor about whether you should go get a mammography, whether you should, et cetera, managing, like, today, that's a very, like, scarce resource. Like, you need to go in person, you need to spend a lot of your time. That's something that can be, like, transformed into being something that's just, like, very ambient and available. So I think those are 3 areas that at least we're spending a lot of time on, to think about how we start automating and think about, using information much more effectively. So at least those are 2 to 3.
And Armin, I want you to add to that and comment, because I bet there's a bunch of similar themes, especially around behavioral change for both patients and physicians.
Yeah, no, this is a great question. So I had some downtime after I left Teladoc, and I was kind of like doing a lot of thinking and reading on this topic. And so my first principle sort of approach here is, if you think of it, like 99% of healthcare is essentially a human interaction. Right? I mean, like the percentage of care that an algorithm is making a decision, except for maybe some things in radiology, maybe some things in like the emerging digital health space, like the personalized medicine, 99% of if you at a global scale, 99% of healthcare interactions is a human interaction. And so what do we get from large language models? What do we get from, multimodal kind of vision, video generation or audio generation kind of models or multimodal models? Is essentially we get a chance or an opportunity to kind of take that human interaction and replace some part of that human interaction with a machine interaction, right? And that's what we think of, like, why is everybody excited about ChatGPT? Because it feels human-like for some things, right? I'm not saying it's AGI or anything. It feels human-like. So I think that's the opportunity. So if you use that lens, I think, and then you follow the logic that Elad also highlighted earlier, there are easy problems and there are hard problems, right? So you look at all human interactions, what are the easy problems that, and easy not because they're technically easy, but easy also because of the risk and safety implications of being wrong, which is very, very crucial in healthcare, right? And so what's easy? Well, taking a doctor's notes, just transcribing it, and sending that over to into the medical record system. That's a use case that you're seeing kind of quite broadly. Prior auth, some of these things where healthcare marketing, where like you will have some kind of human oversight and or the risk of being wrong is quite low. They're hard problems, which I think we probably will see more advances there, if I had to guess, maybe in the next 3 years, 5 years, 7 years. But the hard problems are figuring out the right care model for a person who's being treated by a psychiatry, and you have to titrate medication and figure out the right pathway. I mean, those are hard kind of clinical problems, because I think generative AI will play a role. We're just a couple of steps away from seeing that kind of level of sophistication. And it's not apparent to me whether that's going to happen to like GPT-5 or if it's going to happen to a version of Llama that's specifically trained for like a very specific psychiatry use case. I think both options could exist in like a year or two. We'll find out. So I think I follow that chain of logic and say, like, there's a bunch of places where this kind of human interaction can be augmented by generative AI. And then the question is, like, where should we spend our time? And I think once, this is kind of like a bit of a mercenary view because I have all the scars in healthcare, once the hype settles down, it's going to come down to, like, does it actually drive more engagement of consumers? Does it drive better clinical outcomes? And does it actually help me build a more cost-effective healthcare system? Like, every decision at the end of the day comes down to those 3, right?
Those principles don't change. They're consistent.
They don't change, right?
They're consistent. So let me ask to both of you, AI safety is going to be critical throughout all industries, but we have a very specific burden or responsibility to our patients here. So with the understanding of the inner workings of large language models, how is it progressing? And what are the risks that we are assuming by applying this to healthcare data?
Do you want to go first? Or go for it. Okay, so look, I think with any new technology, there's always going to be risk, right? So I think the first is like, there's risk versus what alternative. There isn't a massive access shortage in our healthcare system, both in the U.S. and globally, right? Pick your favorite statistic. The shortage in psychiatrists. There is a nursing strike. 1 out of 4 nurses are likely to churn in the healthcare system. So pick your favorite part of like the healthcare stack. Like there's an access shortage, and that's before we even talk about the global inequity in healthcare, right? Which is an important topic that I know you mentioned earlier. So I think the question is like, it's compared to what? It's compared to getting nothing. Right? So how do we define systems? How do we build technologies that kind of create the right guardrails, create the right pieces? I think everybody here in this room is probably not a surprise, but I think like clinical safety, clinical safeguards are really going to be important for any sort of clinical-esque use case where it's not just a tool that's going to a provider or going to a nurse or going to a coach, right? So for example, a person could say something in a psychiatry visit, and depending on what they say, I mean, they may be like suicidal intent or homicidal intent there, and that can get escalated really, really fast, right? There's a reason why we have professionals with, decades of training, delivering care. And, I sometimes draw parallels to the safety and risk issues with self-driving cars and the autonomous vehicle industry and in healthcare. And I think autonomous vehicles have had like 15 years or 20 years of a head start, depending on when you start counting. They've had a lot more capital deployed. And arguably, you're replacing, a skill set that more or less everybody in this room has, right? So I think how we think of safety in these systems, and for the clinical use cases in particular, I think is going to be a pretty big challenge, right? And so that has lots of like real-time, like if you're a system like the FDA has an approval process for like efficacy or bias, like when you're updating models, what is the FDA approval process for these things? Like how do you know something's like actually doing the right diagnostic decisions, right? I mean, you guys have probably spent a lot of time thinking about this in cancer and stuff. So I think that's a high level view. We can go deeper into some of those if helpful.
I'll give a response to this that's a bit of a non-answer, but I think actually might be how we actually answer in reality, is that I think when we go and try to replace an existing building block, like the autonomous driving, or in healthcare, like, right now the discussion is like, oh, what happens when you replace a doctor with an LLM? And then the debate is like, here where they outperform versus not. And I think if actually follows maybe patterns from other industries, it might end up being rather, it enables completely new business models and completely new types of services that are actually, we don't even think of them as being a direct replacement. I'll share a story that I've had with someone I know really well for a few weeks ago. So this is a person who's a professor at one of the top cancer centers in the world. And he was diagnosed with cancer in the last year. And so, got all of the tests done, got his cancer sequenced multiple times, and the oncologist in his cancer center, the immediate recommendation was like, okay, yep, the standard of care is that you should go and get chemotherapy now. And he was like, that did not sound like the right way to start, because like this type of tumor did not seem like it responds to chemo very well. Anyways, so we're just gonna go through that process through the motion. But so he just literally went to stock ChatGPT and put in his the mutations that were found in his cancer, and had a conversation asking it what is the right course of treatment. And ChatGPT was like, well, these 3 mutations don't tend to co-occur very often, and kind of explored the path of treatment. And it turned out that like the recommendation that came out was more radiotherapy first. And that had been remarkably effective against his cancer. But the thing that's kind of incredible there is like literally stock ChatGPT gave a better path to treatment for a very complex cancer than one of the best oncologists in one of the best cancer centers in the world. And to me, where my mind went is not the questions like, oh, we should go and replace all oncologists with ChatGPT, but rather realizing that a group of 5 engineers can probably build, and actually we're starting to work on this at Color, but like how do you create a recommendation system or a way to interact with all of the science around cancer treatments to converge towards the best course of treatment. But the crazy thing is that is now you can do that with marginally free, right? Like obviously still costs some money to run ChatGPT and to interact with it, but like it is close enough to free that you can offer a service where everyone in the world can have access to incredible level of insight relative to cancer treatment, and that can literally be free. And so the question is, what are the new business models that can emerge around this? Like, to me, it's like almost like digital advertising showing up in the late 90s, right? Like, that is a complete departure, I think, from the traditional business models. And I think that's what's really exciting.
Shiva, can I ask a follow-on question there? Because this is something I struggle with, which is, so it's great that, let's say, for this particular example of this person, like the system figured out a slightly better answer, or maybe the right answer compared to the advice they were getting from a provider. Before you turn that kind of system on, that's giving cancer advice to consumers, a huge kind of like medical kind of discussion to be had. How do you ensure it's doing that for every situation? Because that's a hard part in healthcare, right? It's like that's a hard part in self-driving cars. It's not the 90% use case. It's the like last 1% is why we don't have cars that were promised in 2017. And I think healthcare is very similar, where it's like, great, we're right 4 out of 5 times or 3 out of 5 times. What about the one time we're wrong? And I don't think the answer is benchmarking these models to USMLE. I think the answer is going to be a different way of building those safety systems or guardrails or oversight systems. Because fundamentally, I think the mistakes that humans make and the mistakes that machines are going to make are going to be quite different. But tell me what's
Let me add to that
Yeah.
as well. What is the framework we need to think about to have a responsible AI in this setting? Because what you've showcased is that healthcare is it's precision. It's very unique to all of us as individuals. There's no one recipe for everybody. But then if we get it wrong, or ChatGPT gets it wrong, what happens?
Yeah, well, so that's where I think it's interesting. Was like I do think it would be irresponsible and very risky right now to go and say, you know what, we're just going to put this in line and replace the oncologists. I think there you're going to have like some outlier cases that are really not good. Right. But the question in my mind is, and I actually don't know yet the answer, but I think the path comes through how do you make this, because we already have a version of that with Google search, right? Like people already go online and can have access to an unbounded amount of medical information, a lot of it good, but some of it really not good, right? And so we have a version, like all doctors, like to complain about people going to Dr. Google, right? And now it's like almost like an extreme version of that. And that's where like I think, yes, it would be very risky to go and say we should replace doctors with it. On the flip side, I think it being possible for this to be completely available for free, that means like any community clinic can literally have better judgment than the oncology center at the Mayo, right? Like that is amazing. And the question is, how do you build more interesting business models around that? Like, so for example, new biotechs putting drugs on the market access is one of the most expensive things you do in biotech, right? Like literally you make a miracle drug and then you still don't have access to the market, right? Like, and you spend billions of dollars to do that. But now, like, maybe there's actually a more direct path to be accessible to all of the oncologists, even if they're not in a very advanced cancer center. Like, it's more those paths that I think are interesting, and still having a human in the loop, but it becomes this incredible tool that is really a big adjunct to that.
Sorry, we're asking you to solve.
I said
We're asking you to solve like what
I
is
said
the
it was going to
subject
be a
of, like,
non-answer
yeah,
answer.
yeah.
So.
It's like there's like 4 PhDs worth of research somewhere in there. But no, I think I think where you're going is right. It feels like the right approach, and it's similar to what we're doing as well with RadiantGraph, which is they go to human oversight and they supercharge the existing kind of clinical or human kind of role that exists. And what that means is the person may be able to do more with their time. And we've seen examples of this, by the way. Different classes of machine learning, but in machine vision and radiology, that's been the model of care, and that's really helped, I think, adoption of these technologies there. So maybe that's a place to learn from.
The other, sorry, we have like 30 questions coming in every second from the audience, so I'm trying to also balance this as well. In regards to new business models, but also supporting different types of geographies, communities, marginalized individuals. Where is the opportunity there? We know that healthcare data tends to be very biased and not representative at all. Where can we begin to fix that problem here?
Please, take a stab. So I think it's worth calling out first, framing the problem. I think there are 2 things, and I want to tease it out. So first is like the issue of like health equity or inequity. This is, I think, a function of just our society, and so there are certain sections of society, there's certain, socioeconomic tiers where like access to care is harder, or clinical outcomes are worse, or, for example, like new moms will have better outcomes in certain sections of society and worse outcomes in other sections of society, right? And I think that's functionally, it's something that exists in our society, so I want to call out the health equity kind of discussion a little bit differently than the other part, which is algorithmic bias, right? Which is like, a bigger issue as well with generative AI. So I think on the health equity side, it's like, okay, I do think that digital tools have been somewhat of an equalizer, right? So like digital health has been powerful because you could be in a rural county and have a 1-hour drive to get access to care, but you can use something like Color, or you can use something like Livongo or Ginger and kind of get the support that you need, right? So I think that's been that's sort of one opportunity, and I think a lot of the common kind of stigma for some conditions, we've seen some early data that shows that that also is help with these experiences. So that's on the health equity side, but there's a lot of work to be done there, and I think there's definitely a lot of, even I'd say at the government level, sort of push to kind of make that part of some of the measures of how healthcare is measured for large organizations, performance and payments and things. And then there's part two, which is algorithmic bias, which is there's the kind of classic example of this is there was, I think, a large health plan that had a system that was predicting like cardiovascular risk, and it was confounding essentially access to care, or like the ability of people to go seek care. And so I think that's the second part of the issue. And I think that's actually a much bigger issue, because when you have a large model, when you have the complexity of like, and often you may not have access to like what the model's been trained on, how do you design tests or systems that need to sit on top of it, right, that are going to say like, hey, here is the kind of like algorithmic bias score for this model for, and it could be not just for healthcare, it's the same for like financial use cases and credit risk and so on. And I think that one, and especially in a world where like, like your people are spinning up new models, or like pre-training or doing additional kind of RLHF on like Llama for some particular healthcare use case. Like, how do you design those safeguards? And I don't necessarily think it's a new agency or stuff like that, and there's been some talk of it. I think it's actually just like coming up with standards, just as we had to think about like these standards in the past for other things that are created. And so I think it's a place where I think startups can play a role and create that layer, that guardrail layer, and think about some of those use cases. But it's an unsolved problem for sure.
Maybe three thoughts on the kind of health equity dimensions in healthcare. I think the first one is that oftentimes some of the biggest sources of inequity are literally the changes in access. When you look at a lot of black communities in the U.S. or people living in rural areas, et cetera, like oftentimes it is not as much about resources and coverage, like people actually do have insurance coverage. Oftentimes it's not an educational problem. A lot of people are aware of the biggest sources of risk, but it's really access. And I think technology in general, but I think especially like now with kind of the generative AI arc, I think can dramatically increase access to all forms of research, whether it's behavioral health or whether it's like, checking your skin for, potential melanoma, et cetera. Like you can dramatically increase access. I think that's number one. I think number two, whenever we see stories about like, this generative AI model, healthcare AI model is seen to be biased. In reality, first cut of a learning model is that it is just a mirror, right? Like it really literally reflects the data we put in and the biases we put in. So it's really a mirror of us. So it really should be like generative AI model finds that humans and society are biased. The cool thing, I think, is that the reinforcement learning and the lens into the bias is much more deterministic. Like it's much harder to train, doctors across the U.S. to be, to treat, like for example, black women during birth, when they report pain levels, to treat it in the same way that they do for a white woman. But that can be actually done with a learning model, I think, potentially much more deterministic way. And I think the third way in which health equity can be, I think, dramatically improved, I think, through the work, is that and actually that's one of the things we're starting to work on at Color, is that a lot of the guidelines that we have, right, like when should you start getting mammographies, when should you start managing cholesterol, et cetera, are based on average population information, including like drug trials, for example, right? Like if you are, an Asian female, like, the likelihood of you having an adverse reaction from a drug that is approved by the FDA is much higher because, everything assumes like it's basically average white males are kind of the baseline. But so much of healthcare assumes it fits to a very low set of features by necessity, right? Like just because it's administered by humans. Whereas I think part of what we can do now is have a much more, much better fit to almost like the efficient frontier of opportunity to figure out when should the person start getting treatment, what type of treatment, so on. So I think that's another dimension where a form of inequity that shows up in a very implicit way, right? Like, when men should start getting tested for prostate cancer with a PSA, the standard guideline, I think right now is 50. It seems to likely move down a little bit, but for black men, they have much higher risk. But that's not currently the general guideline. Most doctors won't recommend it ahead of time. These are the types of things where we can start, I think, fitting much better to much higher granularity features of each person. So I think those are 3 areas.
Those are great. And I want to reinforce what Othman said there. And so with RadiantGraph, which we're still early, but probably the fastest, sort of the biggest use case we're seeing is this idea of a personalized healthcare experience, not in like the clinical lens, but really the experience I have around healthcare. And so the way, 5 or 10 years from now, the way all 3 of us actually get support for maybe the same diagnosis or maybe the same condition might actually be quite fundamentally different. And we know that when people have those experiences, it drives much higher engagement, which is actually a precursor to driving clinical outcomes, which is also a precursor to ultimately driving more economic effectiveness in a value-based care environment that we're in. So it's sort of actually a really exciting use case for generative AI.
Okay, in our last act here, I think the question is AI hype versus reality. So I'm going to start with Othman, because I think we had a great conversation
I'm
about
hyping it up too much right now, so
But thinking about past hype cycles, the mobile wave, the geo, what are the potential unexpected learnings from those experiences that we might be able to apply in this generative AI wave?
Well, one example I was sharing with Zeenat ahead of this is like just kind of looking back at prior cycles. Like, for sure, we're overhyping generative AI and in general right now in one dimension. But I think one of the things that seems to be, has been a relatively recurrent theme is that oftentimes when there's a new building block, a new primitive, all of us get really excited. A lot of the early ideas are first derivatives of that technology. So the example I was using, relating to was, so my prior startup I'd done was in the mobile geo space. It was right when our phone started supporting Geo API, and all of us were super excited about it. And all of us thought there'd be all these location-based apps, like check-in apps, and everyone thought we'd all be checking in on our phones all the time. In practice, you fast forward 10 years, none of those succeeded. All those check-in apps were bad ideas in general. But what was also interesting is that the most successful company that had been founded in that decade was actually a geo app, but none of us think of it that way, and that was Uber. Where Uber is, fundamentally requires that API, but it was far down the stack by the time they just assumed it's part of the fabric. And I think that's probably going to be the case here. There will be world-changing AI, services in the next decade, but none of us will think of them, or maybe our kids won't think of them as AI apps. They'll just think of them, that's how you do, brain surgery or whatever.
Yeah, I think once the hype dies down, at the end of the day, companies and startups survive because they have the business figured out. And I think in healthcare, there's a couple of things that matter. The first is, at the end of the day, every healthcare innovation has to meet the bar of is this improving outcomes? Is this actually driving more adoption or engagement? Is it having an impact on the ROI? So I think we all need to look at generative AI with that lens and find those use cases. I think we're probably overestimating the impact it's going to have in the next 12 or 18 months in healthcare, and maybe I'm wrong, completely wrong, we'll find out. And I think we're underestimating the impact in the next decade, right? And so I think it's going to take some time. And so when I was having this conversation with an investor in the room right before this, and the question is, how do you think of if you're starting a company and you're raising your seed round, or you're investing as a large organization, how do you think of, I would invest for assume this is a 5-year and 10-year horizon. Right? The browser wars in 1999 could not have predicted what Twitter looked like in 2006 or 2007. And I think we're just starting to see what these technologies are capable of. And I think the one thing that I would avoid, I think this is my personal matrix for decision making, avoid anything where you get super hyped up about what can happen next 6 months, and you're not around to actually play the game in 2 years when the technologies are significantly superior. That's my view.
Okay, wonderful. I think we are kind of down to the wire here. One of our goals for being up here is we want it to be controversial. So I guess the last question I'm going to leave the audience with is, what is the one controversial opinion you have around this new wave of generative AI in healthcare? And we'll leave it very open-ended.
start?
Go for it.
It doesn't matter what doctors think.
Can't beat that. Yeah, I mean, I agree with Othman. Rip the Band-Aid off. I think the world is going to look very different, and let's embrace the change. And the bigger reason for that is I don't think the current system is working, by the way. Like, just to make sure that everybody knows this, we are the worst performing in the Western world, in like the developed country when it comes to healthcare, like cost versus like clinical outcomes. So the current system is not working, and so I think listening to the incumbents and holding back innovation, respectfully with doctors in the room, I think let's embrace the change and see where this takes us.
Thank you so much. It was an absolute pleasure to be up here with the two of you.